I'm Velamoor. I'm the president and CEO of NextGen Healthcare.
And I'm Diane, Kaye, the Chief Product Officer, and it's really great to be here with all of you.
So we're really excited to talk to you about how we're thinking about electronic health record systems in the age of agentic AI. So I've been here the last 24 hours walking around the hallways, and there are probably about 2,000 companies here, all of whom have AI in their tagline in some capacity. And I could have sworn that 6 months ago I came to this meeting and the word agentic was not on any of the brochures that I saw here, but we're moving pretty quickly over here. Very quickly about NextGen Healthcare. We've been around for 53 years. We're an EHR company, practice management systems. So we make cloud-based, innovative healthcare IT solutions. And the reason why we thought we had an interesting perspective to share on this is today we serve nearly 10,000 medical groups, over 100,000 physicians, 30 million active patients. We occupy a pretty significant space in the ambulatory healthcare space, touching over 25 clinical specialties. And we're at the forefront of trying to roll out large language models, AI, agents, RPA, mobility, and so on, and putting that in the hands of these care providers and patients to try and transform the payer-provider experience and patient-provider experience. So I'll share a little bit about how we're thinking about. So there was a little bit of stir recently when Satya Nadella and Jeff Bezos and others came out and said agentic AI is essentially going to cause enterprise SaaS technology as we know it to die. Now, we're not necessarily sure that it needs to be that extreme. But our contention is agentic AI might not kill enterprise SaaS platforms, but there is no question that it's going to fundamentally impact the way in which software is developed, managed, upgraded, and managed going forward. Throw a couple of quick stats your way. Today, for folks that are deploying agentic AI capabilities in coding and engineering, they've increased their speed to market by 25 to 30% on average. I think all of us would agree, whether it's healthcare or other sectors, having that kind of agility is massively helpful. Another piece of it that's incredibly interesting is a lot of the workflow solutions, like ours and others that are on the floor over here, many of these were built several decades ago. And the cost of ownership of this technology is pretty significant as well. And the deployment of AI copilots, RPA, into the existing platforms is actually dropping the cost to support these legacy platforms and the technologies by 35 to 40%. So you add those two things up, and there's one thing that's very clear. This is inevitable. It's not a choice. Every one of us, our platforms, others here are going to find a way to deploy it. And the real question is, how do you do it in a way that creates value so this doesn't become another science project? Now, just to calibrate, when we talk about agentic AI, what do we mean by it? 5 things that we believe characterizes what's different. One is the ability to actually use natural language inputs versus what we do, which is form-based entry in software today. Number 2, agentic AI actually is goal-oriented. So everything you do with it works towards achieving some kind of a business outcome or a workflow or process or engineering outcome. And it has the ability to be adaptive and self-reasoning enough to find the best path to get to that outcome. And then the automation and the goal-setting pieces of it are critically important. The key difference is we could roll out RPA in our system today, but the amount of money that it takes, it costs you $1 to install a bot. It costs you another $12 to then put the humans to configure the bot to get it to do what you want it to do. That's today's environment. So the ability to change that paradigm with this technology is absolutely staggering. So enough about that in generic terms. So why are we excited about it as a healthcare IT company? Because we believe that we could fundamentally reimagine the EHR and think about what it could be away from all the traditional constraints that frankly have made it not very exciting or even something that doctors love historically. So with that, let me hand over to Diane and talk a little bit about what's changing.
Yeah, so as I was reflecting this week and coming here, I had a birthday on Monday, and it was a big milestone birthday. And you know, I've been in and around the EHR PM revenue cycle space since the year 2000, which is a long time, right? And as I reflected on it, you think about what's really changed, what changed over the years. You know, clinicians and physicians were tired then, burned out of all the work they brought home at night, right? And it's only gotten increasingly bad in terms of the requirements and care gaps and all the things that are good, but put burdens on clinicians, things for revenue cycle and coding and validating that what you have coded is right. And I really think this is the first breakthrough in terms of this industry that really has the ability to change the nature of the practice of medicine for clinicians and have people wanting to tell their children, no, be a doctor, be a clinician, be a PA, because it's going to go back to an era when actually people can enjoy what they do and focus on the patient care and enable the systems and support that will enable them to focus on the patient. So if you think about where we are today and where we've been, right, every EHR has their versions of workflow and software and forms and templates, right, that have gotten increasingly complex in terms of what data need to be captured, what you need to document, what you need to include, all in a prescribed workflow. And if you're a flexible system, you enable different specialties and clinicians to do some adapting to that. But it's all data capture driven. Again, static data capture, we have lots of data, not a lot of insight. So even with interoperability, right, you need the data exchange in an ambulatory environment with a health system. But how does that all show up for you? Is it a bunch of different documents that then you're supposed to parse through? It's a lot of data, but not a lot of insight at your fingertips. And a lot of clicks, a lot of time, a lot of night, right? That's where we've all been, right? I think the world we're moving to is being reimagined towards this notion of enabling the clinician to do their job in the way they want. So I think we're going to move away from this structured workflow. You do A and then you do B and you do C, or maybe you go A to C, but you always do D after A and B, right? So thinking about how do I engage with a patient, use my voice and be one-on-one with them, and let information be captured in such a way that let the system define whether it goes here or here or here. Because you do have to capture the record, right, and have things in a record. Automated, intuitive, not labor intensive, so I'm clicking. Insight rich, think about this sort of example where you with interoperability, you're getting all this clinical information. But imagine a world where you have information in your record, new information, it's gleaned for the clinician about what's new and different about this discharge of this patient, and it's available to you before you walk in the room with the patient. That's coming soon, I think. And time saving, like all of this is enabled. You as a clinician will always have to sign off. And I think even on the RCM and billing side, right? A lot of talk about RCM, how do we automate the RCM? And my whole thesis is, why do we have denials? Why can't we eliminate it and sort of make sure we're getting information up front right so that we don't have all that queue of labor intensive work to automate away?
I may jump in very quickly. When we set out on this journey looking at how do we use this technology in our EHR, we did the same thing that all of us do naturally. We started with what we had and said, how do we make it a little bit better using this technology? So you hear the word Copilot show up in every software company's conversation here because we're assuming that, hey, the screens we have, the templates we have, the forms, let's just leave it alone. Let's make it a little smarter with AI. Let's make it a little more streamlined with agents. We decided to stop that thinking and just said, clean sheet of paper. Why the heck do we need the screens in the first place? If you have voice enablement, and the screens that we currently have in the forms, they're primarily used for data capture, and they're used to render the data from the database back to you. But if you could use an agent to fundamentally change the way in which information is captured through voice, and the playing back of the results from your database can be done dynamically by an agent, you don't need any of the screens that are currently part of that software product at all. It's a ridiculously audacious perspective, but I think it allows you to really change the paradigm of how we should think about this workflow solution entirely.
So, a couple of things about this. For those of you who are, in clinical environments, many of you, this is sort of an typical ambulatory visit, right? Pre-visit, clinician looks at information before the patient comes in, patient encounter, documentation, coding, and what happens after the visit in terms of checkout and follow-up. But the way we're sort of thinking about this, the new UI is no UI, is some of this can happen synchronously. It doesn't all have to be patterned in that sort of described workflow. But as we were sort of suggesting, and this is, I'm going to try to suggest here what's kind of real and what's being worked on and what is sort of leaning into. But, if you're a clinician, before you go into the patient, you're kind of trying to catch up on previous notes, right? Understand any new patient information that's come in. We are close to a world, very close, where you can say, gee, just summarize the information from the last 2 visits, tell me all the lab results back 5 years, so that really you're being teed up information before you walk into the room in a way that's conducive to the way you want to see the patient and what information is important for you to know in advance of that visit. That is coming soon. Patient encounter, you're working with a patient, you're not at the computer, again, real now, with voice, capturing what you're saying, turning that into your SOAP note, again, so it can be captured in a database that you don't even have to, need to see and know about, completing the exam, defining the diagnosis, and then, the assessment and planning and the orders and tests. We are getting better and better and are close to sort of enabling that ordering based on your voice and based on over time knowledge of, when you do this and this and this and these things are true, suggesting, are these the orders you want? Are these the prescriptions, knowing the history, et cetera? And that is close. So that's really the documentation. Coding is happening. Coding is very close. We are teeing up actually codes and suggestive codes. Again, it's always the physician's or the clinician's decision, but that really is real as well in terms of suggested codes. What's interesting is this notion of clinical information to validate. So we have a lot of clinicians doing this, but they want to see, summarize what I did, summarize my SOAP notes, summarize my action, because I want to make sure that the coding is right. I'm not up-coding, I'm not down-coding, et cetera. But we think that'll go away over time as clinicians sort of say, this is familiar, I know I've done this 100 times, this is the right coding. I think this other piece that we're sort of leaning in and sort of reimagining a new world is this notion of generating a clean claim. Imagine a world where, okay, instead of waiting for clinical documentation, the claim has been submitted, it's been rejected, gee, there was clinical information that was missing, so somebody on your teams has to query you about some information, call the patient, et cetera. That there's sort of a real-time adjudication happening behind the scenes. We need a willing and able partner on the other end, but we're talking to folks about that, such that we could we can be teeing up, hey, don't forget to ask this additional question because we're going to need it for clinical documentation of the order for the MRI you just had. Why do we have to have this cycle after the fact? So we're leaning into that a little bit, not real today, but you can imagine a world where behind the scenes, the information you need both for clinical care, care gaps, orders, billing, is happening simultaneously in real time so that you're going through your visit, closing out your visit, and having everything ready.
Today we spend nearly $170 billion a year as an industry correcting missing information, resubmitting that information purely to make the payer-provider data go back and forth to support this billing workflow. So the ROI is astronomical here, and the data that we have suggests that it's absolutely addressable.
And we've chosen sort of a bit of a clinical and billing example here, but we haven't really talked about the patient. But also, even before the patient comes in, this is real and live, right? Engaging with the patient, ensuring information is collected, knowing if that information is valid, knowing if you're missing something to do an eligibility check in advance of the visit, right? Why does this all have to happen and basically be at the office where somebody's eligibility check failed because the MPI was not available, right? There's ways to be queuing and querying that, so when the patient is pre-visit on a tablet or on their iPhone, sort of completing their documentation, pre-visit, that information is, hey, your social security number seems to be wrong. Let's change that in advance. So leaning a little bit, but a lot of this is really in progress and much of it live now. So again, just summarizing some market stats, 2 in 3 physicians using some form of AI today, 35% of patient encounters. So this is fast. I think we started really on the whole ambient sort of our initiatives before my time at NextGen, but in 2022. And then, everybody was like, well, it'll start slowly. And by 2024, when we have our user group last October, it was amazing, the change over 2 years. And it's just getting faster and faster. So I think this will be incorporated into everything folks are doing clinically, if it's not already. Today, just in terms of some of our stats, 1.5 million patient encounters were leveraging ambient in the last year. This is just, a quote from one of our customers in terms of, how it's changing their lives. Again, at our user group last October, we had a clinician that came up to a mic on one of our AI sessions who literally said, as this comes to life, this will be the thing that brings back clinicians from retirement, because so many people have left the practice of medicine just because they're burned out, had enough. So we do think this is really going to be a game changer in the entire environment.
This is a positive quote. The one I love even more is one where a doctor came up to me and said, "You're going to pry this out of my cold, dead hands." I'm like, well, we'll take that as an endorsement and keep going. So, just in conclusion, agentic AI, real. We believe it's inevitable. The EHRs are absolutely being reimagined based on that. Diane went through a bunch of the use cases that we're evaluating. Every stage of the patient-provider encounter, we're systematically compartmentalizing that and rebuilding each of those in pieces and parts. Within 12 to 15 months, I think you're going to see all of these workflow solutions and these platforms just fundamentally rebuilt from the inside out with an entirely new interface that's more voice and mobility driven than the desktop and the screen-based paradigm that we're seeing right now. We know the doctors love it. The adoption is extremely high. So it really comes down to what's going to get in the way of our ability to truly scale this meaningfully. And our experience on the ground so far is it's not the technology that's the problem. It's funny to sit here and say that in this room when got all these companies here. But our biggest lesson from deploying this to physicians at this point in time is that their desire to want the elbow level support and the change management, to say, I was taught to practice medicine a certain way, I did it a certain way for another 20, 25 years, and now I need to unlearn everything about how I did it and start over. And even though I believe the ROI and the technology works, there is a leap of faith that has to happen for that conversion to occur. So that change management continues to be incredibly important. And the more you show the outcomes, 2 hours of documentation time going down per day for the average physician, 40% faster to pick orders, meds, and codes, 15% improvement in clinical quality accuracy, 30% reduction in errors for clean claim generation and billing and denials. Those are real numbers. And the more you prove that and you do the change management, the likelier that folks are going to use it. That's number one. Number two, move fast but curate thoughtfully. In our desire to innovate really quickly, we talk about fail fast in software all the time. We can't do that in healthcare. Yes, you can have an agent come in and diagnose a radiology image for you or a patient's health for you. But in that speed, to go out and pick a whole bunch of small models and AI agents, we're seeing companies starting to try and stitch together these discrete agents. And if you're not curating thoughtfully, you're going to make big mistakes. Just our experience has been, we had to swap out the speech-to-text model that we were using 3 times over a 9-month period because the accuracy of each model and the quality kept getting better and better. And if we had not curated and designed for that type of flexibility from day one, we would have been stuck with a bad product for the next 2 years. And I think that's true of everyone here in the room as well. And then the last piece of the puzzle, discrete solutions are great, but integration is still king. At the end of the day, there's still value to bring this together in the context of a payer or provider journey. So yes, the tech is awesome, but our learning is make sure that you're looking at the closed loop, whether it's the patient engagement loop or the provider workflow loop, and whatever you're deploying, all the tech needs to stitch together and connect it back to the core platforms that they're used to working with. So we're super excited to be on this journey. We'd love to come back next year and tell you about how all these results have gotten even better. Happy to chat with you guys after the session if you have any questions. Thank you so much.